You who may not know me, I am Dr. Marissa Grant Tate, physician, and more recently oncologist. I am a trained medical oncologist, which is to say that I am trained to take care of the general needs of all cancer patients, as well as those of the specifics in terms of medical treatment and specialized treatment, and more specifically so in the area of chemotherapy. I did postgraduate study as well in radiation oncology, as well as that of clinical research. So needless to say, I'm a lover of oncology. Nurse Blois asked me to come to speak today in respect to breast cancer. As you are aware, this is the month of October, and so then this is perhaps the time of the year as what is a result of the international recognition of breast cancer awareness, that breast cancer is given, I would say, the necessary attention that it is given. However, as a health practitioner in general, and more specifically so, someone who unfortunately has to see what the effects are, both in terms of the community, family, and definitely to those of the patient in respect to the effects of cancer, what I would love to see is that we give attention to cancer on a whole, all year round, and more specifically so definitely in our case breast cancer, as it is the #1 type of cancer for females within the Federation of St. Kitts and Nevis, and it is also to where we have the highest associated death. So just to give you a little backdrop in terms of, cancer and what cancer is, because I know when we hear of the word cancer, then, we automatically think in terms of what is a death sentence. And the truth of the matter is that when it comes to many types of cancers, we perhaps we perhaps could not be any further from the truth. And the reason for that is simply because of the fact that when it comes to breast cancer, once there is a early diagnosis, and we refer to an early diagnosis once it is that the illness would still be localized, then what that means is that there is an extremely high percentage in terms of curation, right? So in other words, then what we have to advocate for is that we are more aware in terms of what we need to do for early detection. So cancer is simply where you have what would have been a simple cell that transforms. It transforms for different reasons. There are different factors that involve, and typically you have to have a combination of these factors occurring for you to eventually end up with cancer. So typically what you would have is that a cell would undergo whatever transformation, whatever change, be it as a result of toxins, which can be chemical, can be physical, can be biological. In other words, in some instances, viruses, bacteria. This is in terms of cancer on a whole. And then once the cell would have been altered, then it has two possibilities. It tries to repair itself, as how every other cell would try and do. And in the event that it is unable to repair itself, then it continues. If the cell is not killed and it is allowed to continue, then what happens is that it loses the ability to control what would have been the ordinary growth processes and patterns of that cell. So in other words, it gets out of hand. No, that's a lack of expression. And so then what happens is that the immune system also plays a very important role in the respect of not allowing cancers to develop. And the reason for that is because of the fact that the immune system is then prepared ordinarily under normal circumstances to be able to attack what would have been this transformed cell and be able to get rid of it. And I know many of us, we hear all the time, oh, we all have cancer, we all have cancer cells, etc., etc. That is not true. We do not all have cancer cells. But in terms of the preformation and the processes that tend to occur to be able to allow for a cancer to develop, then our bodies are constantly undergoing what would be these initial changes. However, in many instances, instances, our immune systems are able to get rid of those cells, and so then we do not evolve to what would be a cancer. Okay, now what that means is that we always have to be very aware of the fact that we are all prone to cancers. Yeah, because if it is that we are all constantly in a state of where we have the normal states of transformation of cells that can evolve to cancer, we don't all have cancers, but we have to be aware of the fact that we all have the possibility. And so then when we realize that, then it makes it a bit easier in understanding why it is that we have to be more cautious in terms of the things that we can actually control. So when it comes to breast cancer specifically, breast cancer is simply that of the breast. So you would have had the transformation of the cell, it evolves, and then it eventually gets out of hand. There is no specific reason that we can say why it is that some women get breast cancer and why not others. Okay, so unfortunately we cannot say definitively what causes breast cancer, but we do know that there are a number of factors that favor the start or the instance of a breast cancer, and as well too there are protective factors. So there are things as well that can in fact help to reduce what would be the risk of breast cancer. So very specifically in terms of the risk factors, one of the first things obviously would be the fact that we are women. Women, we have the absolute highest risk when it comes to breast cancer. For every 200 women that have or will be diagnosed with breast cancer, only one male would be diagnosed with breast cancer. And in terms of the incidence, then 1 out of every 8 women will be diagnosed with breast cancer. Yeah. In terms of the death toll, and again too, we have to be aware of the fact that breast cancer unfortunately is quite deadly once it is diagnosed in what would be the more advanced stages. And as a result of what is poor detection in respect to early detection rather, then what you find is that quite a bit of cases, overwhelmingly so, ultimately end with what is an unfavorable prognosis. Other risk factors that we would have to bear in mind, apart from the fact of being a woman, would also be to what would be a family history. Family history is not, however, definitely or indicative that you will be diagnosed with a breast cancer. What it does though is that it helps to increase the possibility. Very often many women, when I see them for the first time and I ask them, do you have a family history? The answer is usually no. So this again too helps to highlight the fact that family history, although there may not be a family history, we still have to be mindful of what is the risk. We also take into consideration the age of the individual. Breast cancer is an illness that we see typically within what would be the 40s, late 40s year of age. Generally, the highest peak you tend to see is between the ages of 45 to 52, and then there is a second incidence in terms of spike where you would find it within the menopausal woman. So in other words, ladies postmenopausal rather, typically what would be about from the age of 62. But anywhere from what would be an average of about 40 years, then we have to be on higher alert in terms of suspicion for breast cancer. Yeah. However, that does not mean that younger women do not end up with breast cancer. Although, to be fair, only about 3% of the cases are actually diagnosed before the ages of 30. Yeah? But it is important to point out that being a woman, that is in fact the highest risk factor. Other things that we take into consideration would be lifestyle. Obesity, for example. Obesity. As a result, obviously, of what would be, as a result of what would be obviously a very high caloric diet. So in other words, foods built in fats, food built in excess sugar, and so forth. And the reason for that, simply put, is that the body, it uses the cholesterol to be able to synthesize the sex hormones. And the sex hormone that has been identified as being perhaps the greatest contributor to breast cancer, which is why we have it much more greater so in women than in men, would be the estrogens. Okay, and so then this cholesterol, in other words, and having had that high diet and so forth, that increases the likelihood of us being diagnosed with breast cancer. We also take into consideration, and definitely so, the past medical history of having had a cancer. Very often, women who would have been diagnosed with breast cancer, they're able to get out of the woods, for lack of a better expression. They sometimes forget the necessity for what would be continued screening and so forth and surveillance. And in fact, having had a cancer, and more specifically a breast cancer, is one of the highest risk factors for having cancer of the breast again. There are other family illnesses that we look at, and sometimes so it might not necessarily be associated specifically with a breast cancer, but there are some syndromes, for example, what we would refer to as Lynch's syndrome, where what you have is a combination of different illnesses that can arise in terms of different types of cancers that can arise from this particular family illness. And it may manifest itself as what would be an ovarian cancer. It may manifest itself as what would be a cancer of the colon. It may manifest itself in terms of what would be the cancer of the breast. And more recently so too, it has been identified over recent years in respect to prostate cancer. So all in all, to say that there are quite a number of cancers. I really don't want to overwhelm you with the factors themselves, but I would highlight and say what the more important ones are, which would come down to the age of the individual, one being female definitely, two the age of the individual, family history, and our lifestyle. These are the more important factors, right? Because they are countless. At the same time too, there are some protective factors, and you know, we might say, well, how is that possible? But there are in fact protective factors. If a woman would have been, if a woman, for example, who would have had, let's say, for example, her ovaries removed, and if this is practiced before the age of 35, that in fact reduces the risk of breast cancer by 70%. If a woman would have had her first child by the age of 20, that reduces the risk, or within the 20s, let's do that one first, within the 20s, then that reduces the risk by 50% compared to the general population. If a woman would have had that first child before 20, then that helps to decrease the risk by an additional third. So then what you find is that not what we typically bend on in terms of the factors of breastfeeding and so forth, because in fact and in actuality, breastfeeding has no impact whatsoever on the possibility of a breast cancer. However, the age at which a woman has her child, that is an important factor, okay? And that too helps us, because I'm sure when we look around, we say, well, you know, where all of these cancers are coming from, you know, grandmothers, you know, they lived for so many years and they had so many children, whatever, and they never had breast cancer and so forth. And then we find more and more young women ending up with breast cancer, and middle-aged women and so forth, and we wonder, well, you know, how and why? So these are all things that we have to take into consideration. In terms of the treatment, to not bore you with the whole medical jargon and so forth, but in terms of, or maybe I should go first in terms of diagnosis. So in respect to diagnosis, just to point out that overwhelmingly so, a grand percentage of women actually detect the lump themselves. And this is more and true in societies that have what would be a greater sense in terms of self-month breast examinations. Yeah, and so then this is also one of the reasons why we emphasize on what would be the breast examinations, your auto examination of the breast every month, because then this allows you to be able to detect what would be a change, what would be a lump that is not ordinarily there, okay? And so then this allows for what would be an early diagnosis, and it allows for what would be the necessary treatment within the correct period of time. So, month-to-month breast examinations, we also know too that we emphasize on what would be the annual mammogram, but I want to remind us that the mammogram, it does not diminish the purposefulness and the use and the value of what is the month-to-month self-examination of the breast. Bearing in mind, mammograms, they are once a year, and you have 12 months in a year. Yeah, and so then what that means is that the mammogram, if it's there at that point in time, then the mammogram will be able to pick it up. But if it appears in one of the other months, then what is your chance? You have to be able to try and pick it up with your self-examination. If you have what is a high family history risk as well, then it is also recommended, because again, the mammogram, that is something that is typically reserved for women above 40. And so then you might be a young woman who might have had a history of family cancer, breast cancer in particular, and more so along the lines of what would have been one of the earlier ages having had been diagnosed. And so then in that instance, then you are also encouraged to ensure not only that you do your breast month examination, but that you also make sure that you do what is going to be the medical examination. If you have that family history, then your medical examination should be every 6 months of the breast. If there's no family history, then you can have that medical examination annually, right? So we have to again come back to what our family history is. Yeah, right. So the other aspects in terms of diagnosis, and perhaps the most important form in terms of diagnosis, would be the biopsy. I made mention of mammogram, and I neglected to speak, sorry, in terms of ultrasound, but the ultrasound too is also quite useful, and particularly in what would be a younger woman, and even so too in a more mature woman. The ultrasound allows us to be able to know whether it is that the lump that you are feeling, if it is that it is a solid lump, or if it is that it has liquid on the inside, and that is significant when it comes to being able to diagnose. But the ultimate diagnosis comes down to what is going to be the biopsy. Yeah, there are different types of biopsies that can be done. The biopsies that I know very often, when individuals feel a lump, then they stay at home and they hope that it is going to disappear. They pray that, you know, this is going to go away, and they are fearful of what is the biopsy. Perhaps maybe for more reason than one. One is in terms of, you know, coming to find out what exactly it is and whether it is that it is in fact a cancer. And then the other part of it is whatever reservation that some may have in terms of having what is a surgical procedure. However, the biopsy is extremely important to be able to confirm the diagnosis. And there are different types of biopsies. There are non-surgical biopsies, and then there are surgical biopsies. So all of them do not necessarily amount to what would be having to go under anesthesia and so forth. And really, women should be encouraged, you know, so that if for whatever reason you feel something, then you discuss the different possibilities with your doctor, right? But you don't say, well, I don't want to have surgery, and so then I'm not going to go and get this thing checked out. Okay, so we've completed in respect to the diagnosis, and then I'll just touch a bit in terms of treatment. The treatment is extremely extensive when it comes to breast cancer. There are a number of types of treatment, modalities that we use when it comes to cancer, and more specifically cancer of the breast. I would start perhaps with surgery, as it is the only curative form for breast cancer. So if there is a breast cancer and for whatever reason there is not the possibility of surgery, then what that means is that we no longer have the possibility of actually curing the illness itself. Okay? However, surgery may not always be the first available option. Based on the size of the tumor, based on how it might have spread or not, then it may become necessary to do other forms of treatment, which could include chemotherapy, radiotherapy, immunotherapy, hormonal therapy, and so forth and so forth. So in essence, the treatment, it involves a number of different areas, but it comes down to what is required for that individual patient at that time. So the treatment, although there is that general basket, then we still have to make sure that it is tailored to the actual patient themselves. I imagine that you're going to have questions, and I know that that is probably where I would be able to be of best use in terms of answering what might be some doubts, questions, or concerns that you have. So I would leave this part of it for us to be able to do that, if that's okay with you now. Yeah. No questions? It was so complete.
I have a question. Somebody have any question?
Give up.
Okay, I am above 30. I'm not gonna say exactly how much, but I have a family history where my aunt died from breast cancer. How often would you say that I should have a breast examination, being at my age? And in addition to the fact that I had my son, my only son, before the age of 20.
Right, so at the same time you have a combination of protective factors, and then you have two what would be risk factors. So what I would advise is that we still err on the side of precaution, and so then what we would do is to practice as if there were no protective factors. And the reason for that is simply because of the fact that although we have, just as we have risk factors, we have the protective factors. While the protective factors, they help, but they do not eliminate the risk, and so then it is not as easy to gauge. So what I would suggest is that you would then do your medical breast examinations every 6 months. If you are aware of the age at which your aunt would have been diagnosed, then it would be advised that you would start with what would be the ultrasounds at least 5 years before the age that she would have been diagnosed at. If you are unaware of the age, then for your age you can simply begin doing the ultrasounds as well, but at least once a year. So ultrasounds of the breast once a year, month-to-month breast examinations that you would do at home yourself, and in respect to the medical breast examinations every 6 months.
Thank you.
You're welcome.
Any other questions? I have another question. So you would your advice would be to start with the ultrasound as opposed to the mammogram.
Right, because of the fact that you're not yet at 40, then what happens is that the breast tissue, the composition of the breast tissue, the mammogram isn't going to be able to get to see a whole lot. And so then what we do is we emphasize on the ultrasound, which would allow to see if it is that there is a lump there. And then from that, for whatever reason, let's say they were to detect a lump, then most likely it would be followed through with a mammogram to look for other signs that can be associated, microcalcifications and so forth. But basically with the mammogram, because of what is the density of a more youthful breast, then you tend not to be able to see as much in terms of detail that you would be able to see with the ultrasound.
Does the amount of children you have decreases your risk?
Not at all, and that is a very good question. The protective factor in terms of reduction of risk, it literally just comes down to the age of the first child, and this is because of the fact that, well, you know, there are 3 different estrogen hormones, and when we consider that the hormone under which the breast undergo what would be their proliferative state during a period that we refer to as the estrogen window. The estrogen window, that is another thing too in terms of risk factors that we look at, but the estrogen window, it is opened when we start with the first period, what we refer to as the menarche, and then it closes with the menopause, right? Thank you. And so then what happens is that for a woman who would have started to menstruate at a very early age and then she goes into menopause at a later age, then she has a much higher risk than, say, a woman who would have started to menstruate at a older age and gone into menopause at a younger age. And the reason for that is that you have what is a wider span during you know, that window. And so then what happens is that during that window, then the breasts, they are under the effect of the estrogens. So specifically the estrogen that we refer to as estradiol, this is what allows for what is a continuous proliferation, you know, of the breast tissue. And so then once it is that you have what is the first full-term pregnancy, even if it is that the pregnancy does not end with a live birth, but it was able to attain what is the full-term status, then at that time, then you have the necessary estriol hormone, which is then going to be sufficiently high to be able to block the effect of the estradiol. And so then what that does is that it takes the breast out of that proliferative state. So then if this process occurs before the age of 20, then you really get to decrease that risk. Again, we're not advocating for teenage pregnancy and so forth. However, we just need to emphasize on making sure that women understand you know, what it is that is occurring and how it is that we end up at greater risk. And we see more cancers now because of the fact that women are delaying that first pregnancy. Women, they're going to university, they're, you know, working on families, they're waiting on that ring, you know, etc., etc. And so then what happens is that these pregnancies, in terms of the first pregnancy, it is occurring at much later ages. But then if it occurs by 35 or after, it's as if it has never occurred at all. Okay? And so then you do not get what is going to be the benefit of the protective factor if it's after 35. And if it's by 30, then again you would have increased the risk by about 50%. So there are a whole lot of, you know, small but important factors.
Not a question, but a request.
Sure.
Please touch a bit on breast cancer in males.
Okay.
Symptoms, both males and females.
Right, no problem. So in terms of breast cancer in men, again, you know, and this is not at all to dispel the incidence, and I guess to why we emphasize more so on women is because of the fact that overwhelmingly so 99% of the cases of breast cancer are women, and so only 1% end up being men. But in the United States, for example, where you have, you know, over 2 million or 2 million average of 2 million cases per annum, then that amounts to 2,000 men typically within that year having been diagnosed. So but the factors are typically more so associated with what is going to be that genetic risk, that family history. So in the instance of where a man might have what is a strong family history, then this is the man who has to be even more particular about what is going to be a breast cancer. So if it is that you have what is, a first line relative, be it a mother, be it a sister, be it a brother, be it your father, just as how the woman would have to be a little more observant in that instance, then you too as a man, you have to be a bit more observant. And so of course you do your month-to-month breast examination. In terms of these symptoms, and I guess as an oncologist, we tend to omit quite a bit in terms of symptoms. And the reason for that is that we want to emphasize that symptomology is not what we are waiting for. When it comes to breast cancer, we have to be more proactive, and so then we want to be able to get there before you can get symptoms. But nonetheless, the most frequent, and so then for that reason too, what we refer to as the most frequent symptom is not typically what others would refer to as a symptom, which is the presence of that lump. But that is for us the first symptom. So when you do your month-to-month breast examination, you should be feeling for what could be the presence of a lump. Other things can involve changes in terms of the color of the breast compared to the other one, can involve what would be change in terms of the size, whether it is that there's an increase in one compared to the other, whether it is that the skin might have some dimpling on it or not, whether it is that the nipple is retracted, right? So it might be a bit in compared to the other. There can be a nipple discharge in some instances, but the absence of any of these symptoms does not exclude that there is the possibility or the presence of a breast cancer. And so then again, we emphasize on what is the very necessary month-to-month breast examination. In respect to men, and typically to literature ordinarily pointed to what was a more grim prognosis when it would come to men for breast cancer. But the breast cancer with men, it is the same exact breast cancer with women. It is special, however, because of the fact that men do not have as much breast tissue. And so then what that means is that in a woman who would have had that same breast cancer, there is more space for that lump to be able to grow and still be considered localized. So it hasn't had the opportunity yet to be able to spread. But with a man now, because there is not a whole lot of breast tissue very quickly, then it is able to spread, and so then it goes to, well, the nodes of the different areas, the nodes, the regional nodes rather, as we would refer to them, and then it has a quicker possibility in terms of metastasizing or spreading to the other organs. And so then that gives what is an image of it being more aggressive, but it is not any more aggressive in fact in terms of biologically. It's just that it doesn't have as much breast tissue to be able to affect.
Thank you.
You're welcome. There are also other special instances of breast cancer that we tend to neglect. For example, there is breast cancer that is diagnosed in pregnancy. And when you have a breast cancer that is diagnosed in pregnancy, it doesn't prohibit treatment either. What we look at specifically the time of the diagnosis in terms of what trimester the individual would have been diagnosed at. And so then we are able to better gauge for what part of treatment should be given when, okay? But there is treatment as well. What happens too though, when it comes to breast cancer during pregnancy, because of the fact that the breasts, they tend to become very voluminous during a pregnancy, then it is often too lately diagnosed in a woman who is pregnant. And that is because of the fact that, again, this is not going to be very easily detected, neither by the woman and perhaps maybe to a large extent her physician, because of what would be, the increase in size in terms of the breast. You have other things as well, but quite a few of them which aren't really into practice in terms of risk factors. When we look at, for example, hormonal therapy, and that is an important part of it. Women who typically would be going through menopause, for example, they would often be prescribed the estrogens to be able to alleviate the symptoms and so forth. And that is a risk factor that increases the risk for breast cancer significantly. Women though who, for example, undergo or use what is birth control, once it is that the birth control is what is marketed as no, which is, you know, the combined pill, then that does not affect your risk whatsoever. So using your birth control pill, it does not increase your risk of breast cancer. The only thing that the birth control pill can do in terms of favoring towards the breast cancer is if it is that you have not had that first pregnancy, and so then the birth control pill is helping to put off that first pregnancy, right? But the actual pill itself, in terms of hormonal, does not directly cause you or affect you in terms of breast cancer risk.
And the same for the injection?
The same thing for the injection. And then there are some other drugs, for example, risperidone, for example, which is often used in terms of some psychiatric illnesses, that helps to increase the risk for breast cancer. Hypothyroidism, which we know quite a few individuals have, you know, that too helps to increase your risk for breast cancer. So I guess what I want to do is to emphasize on the fact that at the end of the day, we all probably have one or more risk factors, and so then what we have to do is to emphasize on that month-to-month breast examination, because ultimately then that is what is key in terms of being able to prevent death by cancer. We're not able to prevent the cancer itself because unfortunately when it comes to breast cancer, there is no pre-malignant lesion, there is no predisposing and direct evidence of something that is going to evolve into a cancer. And so then it becomes necessary for us to be able to insist on what is early detection. Yeah. Let me just highlight as well too, since in respect to there is another special form of breast cancer, what we refer to as Paget's disease. And Paget's disease specifically, it doesn't typically manifest as what would be ordinary or other forms of breast cancer. With the Paget's disease, what happens is that there's typically a rash that is associated. It can be it can be a dry, white, flaky sort of aspect, or it can simply manifest itself in the sense of what would be bumps, you know, with some amount of pus and that sort of thing. And in the other instance, then you might actually be able to palpate what is a node along with it. But the reason why I want to highlight that is because of the fact that, you know, very often to women, they sometimes end up with what would be a rash on the breast, and then the first thing they would say is, well, you know, it's probably the bra. But if it is that you have a rash on the breast, and particularly in the area of the areola, then it is important that once it is that that rash is not resolved in 2 weeks, that you make sure that you follow up so that it can be tested, okay? Because then that could be what is the presentation of a Paget's disease, even without what is the presence of a lump.
So the Paget's disease is what they look like an orange skin peel?
No, the orange skin peel is what you get typically with breast cancer when it is advanced. And what happens is that because of the fact that the tumor, it tends to pull on the skin, and so then what that does is that it causes the pores to become more obvious, and so then it gives the aspect of what is an orange peel. Right. But that is a symptom that is associated with, you know, that breast cancer that is quite advanced. So again, we're trying to catch the breast cancers well before that phase, well before that. Yeah. So if there are no more questions.
When somebody do a mastectomy,
Right. Mm-hmm.
when somebody do a mastectomy, you anyway think that the repairs
In terms of the cosmetic repair?
Yes.
Okay, so I'm not absolutely certain in terms of the the reconstruction of the breast in respect to the surgery here, to be fair. However, I would like to highlight the fact that when it comes to the mastectomy, then it does not always have to be what is going to be that radical, modified radical mastectomy. So in other words, then it doesn't always have to be that the entire breast is removed. The doctor will be able to evaluate, the surgeon will be able to evaluate based on what would be the size of the tumor compared to the size of the breast, the localization in terms of the tumor, whether it is that there is a single tumor or if there are many different tumors in the breast, and so then be able to discuss what is the possibility of having a more conservative surgery. And once it is possible to do that, then that is what they are encouraged to do. And the reason for that is that the chopping it all off, and I say that deliberately because of the fact that I've had instances where patients who would have been fortunate to have what is the conservative surgery done, in other words, simply have the area that is affected removed and so forth, and then when they go back out into their community, then other women, you know, insist of them, why don't you just go back and take off the whole thing? You know, this is going to allow it to come back and so forth and so forth. And that is not true. The surgery in terms of the complete, or rather the radical mastectomy, it does not give any higher benefit in terms of preventing the return of the cancer compared to what is the conservative one in terms of the partial mastectomy. What happens though is that if a woman has a partial mastectomy, then she has to be able to ensure that she will be able to follow through in terms of the very expensive follow-up treatment, which is radiotherapy. And radiotherapy is quite expensive. So if it is that you're not going to be able to afford radiotherapy, then at that point in time you will be encouraged to have the total, rather the radical mastectomy, because the radiation is necessary to ensure that you do not have a higher risk of it coming back once it is that you would have had a partial.
About the treatment, I have surgery, chemotherapy, and hormonal therapy. What is the one was just now?
Radiotherapy.
That's all?
We also have immunotherapy. The beauty about treatment is that every day there is something that is new and evolving. To be quite fair, before COVID, I could say that cancer research is perhaps where most of the world's resources go in terms of medical research on a whole. But right now, even the cancer researchers, they have paused quite a bit, and they are now too dedicated to what is the research in respect to the COVID-19. So, but treatment is always evolving, and within what would be the bracket of immunotherapy, then that in itself is quite extensive. And it continues to expand. But what we are finding is that more and more we are able to allow women to live much longer, much more productive lives in terms of, you know, the quality of life and so forth. But we simply cannot omit to emphasize on what is the need for an early diagnosis, right? The early diagnosis is key. And for the early diagnosis, then it comes back to your month-to-month examinations and making sure that once it is that you're at the age of mammograms, then you do, which is from 40. And then we insist that you get your annual mammogram. And again, if you have a family history, but you are not yet 40, then you ensure that you get what is going to be that ultrasound.
And the treatment that you mentioned, you have all of these treatments here in St. Kitts and Nevis?
We do not have radiation therapy. We do not do radiotherapy. But the reason for that is because, to be quite fair, we honestly do not have the population to be able to sustain what is a radiotherapy unit. Even countries, for example, like Antigua has a radiotherapy center. And they still struggle quite a bit in terms of what is the maintenance in terms of costs compared to what the region is able to provide them with in terms of patients. So radiotherapy, it's expensive in terms of the operative cost, and so then it really there's really absolutely no place, to be fair, for us to have a radiotherapy unit here. We simply would not be able to sustain it. Everything else is available though. Right? Right. And again, too, not all patients will require radiotherapy. Radiotherapy, this, is again a specific modality that is implemented on the specific circumstances. But if it's a very early diagnosis, then it is much less likely that radiotherapy would become necessary. Yeah, so if we don't have any more questions, then I think we should be able to close. Yeah? Okay. Thank you.
Dr. Grant, on behalf of the KNA, we want to thank you for such an informative session. I'm sure we learned a very much lot. So once again, we want to say thank you, and I want to implore everybody to make sure that you do your monthly examinations. Notice that she stressed a lot on that, and that if you don't have insurance, please get insurance, because health is very expensive.
Yeah.
So once again, we want to thank you for taking out time out of your busy schedule to come and enlighten us.
Thank you.